Hello, everyone. We're in the safety of our own home right now, and that's why none of us are wearing masks at this time. Today, we're going to be talking about adrenal masses and the workup. My name is Sarika Rao. I'm an endocrinologist at Mayo Clinic in Florida, and I'm joined by my colleagues, and we work all together to help diagnose and determine the upcoming treatments for your adrenal mass.
Hi, I'm J.D. Lagoo with the Department of Radiology with interests in abdominal imaging and MRI.
Hello, I am Ricardo Paz Fumagalli. I go by Paz, Dr. Paz. I'm an interventional radiologist, and I have a brief but important role in the management of adrenal masses.
Hi, I'm Dr. Enrique Eli. I'm one of the minimal invasive surgeons here at Mayo Clinic. One of my expertise and my interest is the minimal invasive treatment of the adrenal gland. We have a robust experience here in our practice, so very happy to be part of this team.
All right, thank you guys all for joining us today. So we're talking about adrenal masses. The adrenal gland, I like to always point like this. It's a triangular shaped gland. It sits above the kidney, and so therefore we have two of them. And it basically is very helpful in making different hormones in the body, making steroids that help control our blood pressure and help us fight infections and kind of the sodium or salt in our body, as well as adrenaline that gives energy and also assists with blood pressure. So Dr. Lagoud, if you can show us some examples of the adrenal gland, what a normal adrenal gland looks like, and kind of what you see that leads to the workup for all of us.
So we're looking at an axial CT image. If you're not familiar with that, you can imagine that we're standing at the patient's head and looking down towards their feet. And to orient you, this would be the liver on the right, the spleen on the left, and then the spine in the back. The adrenal glands are paired structures in the upper abdomen. They have sort of an upside down V shape. We can see here and here. If we look at another orientation where we're looking face to face with the patient, we can see that they live directly above the kidneys, which would be here and here. And then the normal appearance would be thin, smooth contour as those limbs flare out into that adrenal, the upside down V shape.
Usually these masses are found by accident through radiology, sometimes through symptoms that a patient experiences, which we'll discuss a little later, but I know you as a radiologist find this a lot. And
yeah, so most of the adrenal masses will be discovered incidentally on imaging done for another purpose. And so we know if the patient's asymptomatic and they don't have any known cancers, that almost all of these masses are going to be benign. The vast majority of them, over 75%, will be an adrenal adenoma. Adenomas are quite common, benign lesions. Are usually small, less than 3 centimeters, and they occur increasingly common, or they become increasingly common as we age. Fortunately, we can diagnose almost all of these with non-invasive imaging techniques with CT or MRI. Most can be diagnosed with simple measurements on a non-contrast CT. So here we have an example of a typical adrenal adenoma. We would perform a simple density measurement on the non-contrast CT. And if it's uniform low density, we can confidently diagnose an adenoma. If you get your CT scan done at Mayo Clinic, we'll start with that non-contrast CT. Your radiologist will check those images while you're on the scanner. And if we can diagnose an adenoma based on those measurements, we can stop there. We can spare you the contrast administration, any additional radiation exposure from additional imaging. If we make those measurements and we can't diagnose an adenoma, then we can proceed with contrast administration. Doing that, we can get additional measurements at set time points after we give contrast, and that allows us to diagnose most of the remainder of the adrenal masses. We can differentiate between lesions that are almost certainly benign and those that could potentially be malignant and might require additional workup or tissue sampling to diagnose. Here we can see an example of that. We had a non-contrast CT and then gave contrast and had additional measurements that showed rapid enhancement and washout, which would be typical of an adrenal adenoma. We can also diagnose adenomas very accurately with MRI. What we're looking for on MRI is areas of intracellular lipid. which would be characteristic of an adenoma. We use something called in and out of phase imaging to accomplish this. So here's an example of a typical adenoma on MRI. We can see the in phase image, the adrenal adenoma quite bright. And then what we're looking for is areas of darkening or signal loss on that out of phase image. And if it's uniform signal loss on this sequence, we can diagnose an adrenal adenoma. Another example where we see that signal drop out on the out of phase image, diagnosing a benign adrenal adenoma. The second most common benign adrenal mass is an adrenal myelolipoma. These can be more variable in size, composition, and appearance on imaging, but we can still diagnose almost all of these lesions with non-invasive means with either CT or MRI. These masses, what we're looking for is areas of actually macroscopic fat or fatty tissue elements forming within their composition. And we can identify that with CT, where we have here 3 examples of adrenal myelolipomas in the left adrenal gland, kind of showing the different looks we can see with these. And what we're looking for is low density areas of fatty tissue signal. So here this mass, almost entirely fatty tissue, a myelolipoma. Here one that's more soft tissue elements and admixed fatty elements. And then here one that's mostly soft tissue, but we see the flex, small areas of fatty tissue elements that we can diagnose all 3 as adrenal myelolipomas. We can also diagnose those on MRI. We use a little bit different technique where we apply a fat saturation pulse. And so here we can see what that would look like. We have a lesion that's fairly bright on our T1 weighted image. And then when we apply that fat saturation pulse, those fatty tissue elements get darker, confirming that it's truly fatty tissue and diagnostic of an adrenal myelolipoma. So the quality of imaging is very important for getting an accurate diagnosis and seeing what's going on in these cases. And the quality of imaging can be quite variable, especially with abdominal MRI throughout the community. So we're very lucky here at Mayo Clinic. We have access to the most up-to-date and highest quality scanners and software, and have physicians that have expertise and specialize in this area and with these pathologies. So we're able to provide the highest quality imaging to get the best chance at a non-invasive imaging diagnosis for most of these pathologies. So whether you're coming to Mayo Clinic or you're going elsewhere, I'd still encourage you, especially if you're getting an abdominal MRI, to try and seek out the highest quality imaging center that's available in your area. All right, hand it back to you, Dr. Rao.
Yeah, so he brought up a very good point. You know, these masses are found by accident. A lot of patients never would have known that they had any masses, and this is true for a lot of our endocrine glands. We see nodules, you know, even on the thyroid as well. But one of my specific interests is with the adrenal gland, and so when we see these masses, whoever had originally ordered that CT or MRI, or if a patient, you know, has a question about this finding, then they often come to us as endocrinologists first. And so the imaging component is important to help, you know, guide us in terms of our workup. But the other thing we look at is whether this mass is making any hormone or not. And the majority of these masses, as Dr. Good was mentioning, are benign. But even if they're benign, they could still be making excessive hormones, kind of like what I was alluding to before. And so there are 3 different hormones that we primarily are screening for 3 separate conditions. One is known as Cushing's, and there are different forms of Cushing's, but basically that's an overproduction of cortisol, which is a steroid. And patients who have this condition, they often have increased weight gain primarily in the middle part of their body. Their arms and legs are generally very thin. They develop puffiness in the face, as well as like a, you know, almost, we call it a buffalo hump, but like in the back of the neck, there's a little bit of an enlargement, easy bruising, blood pressure can often go up, and some patients may have increased infections or thrush as well. And so, you know, when we find this based on certain labs that we perform, then, you know, we have a specific plan for that. Similarly, there's another condition where a patient may be making too much aldosterone, which is similar to cortisol, but more specifically is related to high blood pressure, as well as a low potassium level. And so there's a series of tests that we would do to screen for that condition. Most of these tests are all blood tests, and they're quite quick, but depending on each result, then we have a next step to do. And then the other condition that we're always screening for it's a long name, it's called pheochromocytoma, but basically that's where the adrenal is overproducing adrenaline. And our radiologists are usually going to indicate something like that. It wouldn't be described as an adenoma typically on the MRI. Adenoma, refers to like a fatty enlargement of the adrenal gland. So the pheochromocytomas do look a little bit different on the MRI or the CT. And so when we have these, if we find that there is no hormonal presence, then we can decide to, and it's just a benign enlargement, then your endocrinologist or your physician who's working you up for this can decide on what kind of management is needed. And part of it is dependent on the imaging features, part of it is on the labs. Some physicians may stop workup. But sometimes if the hormone is present, there are a few situations where we see masses on both adrenal glands. Doesn't happen too commonly, but of course it can. Particularly, there are two hormones, the aldosterone, which affects the salt and blood pressure, as well as the cortisol level. And sometimes we see these enlargements. There's a procedure that can be done to help decide if one of those masses are overproducing hormone or not, because we would not want to subject someone to taking out both masses. And so this procedure needs to be preferably performed at an institution that does this a lot. And the reason for that is it's a very highly technical procedure. The anatomy varies in each person, and the interventional radiologist would need to accommodate for that and have an understanding of what to do. And Dr. Paz here at Mayo is very experienced with this procedure, has a very high success rate, and almost 100%, I believe, or 100% success rate. And so he's going to tell us a little bit more about this procedure and kind of what he's looking for and some of the outcomes.
Thank you, Dr. Rao. Indeed, it is a technical challenge in some occasions to perform these procedures, which we call adrenal vein sampling. Fortunately, Mayo Clinic has a century-and-a-half-long reputation of endocrine diseases, and for that reason, diseases that normally are seen only very occasionally or rarely out in community hospitals, we see more on a routine basis because they are referred to us. And that gives us the opportunity to develop an expertise that it just grows over the years. I have been doing adrenal vein samplings for 30 years, and that provides a perspective and a certain bag of tricks that can be applied to patients that are particularly challenging. The purpose of the examination or the testing, this so-called adrenal vein sampling, is to make the determination that Dr. Rao was talking about. We need to know whether one, the other, or both glands are responsible for the excessive production of hormone. Now, that hormone can be most often aldosterone, but as Dr. Rao was indicating, it could be for other things such as cortisol, or also rarely, it could also be gonadal type of hormones. Mm-hmm. So for all of these disorders, occasionally we are asked to participate in patients' care. So what is this testing all about? The idea is to acknowledge first that the blood work that is done routinely in patients, as well as the imaging, which is very helpful, does not entirely tell us which side is responsible, because lumps and bumps in the adrenal glands are quite common. So we don't really know ahead of time which gland will be implicated. So the idea then is to take a sample of blood directly from each vein before that blood gets to the main vein of the abdomen, where it'll mix immediately, making it impossible to tell the two glands apart. So how do we do this? The first thing is actually done by the endocrinologist. The patient needs to be under conditions that will ensure that we will get a quality examination. And that has to do with figuring out medications that are on board. Some interfere with the testing. Sometimes the potassium levels may be off and need to be corrected. So that is groundwork that is done by the endocrinologist. Once the patient is prepared, they come to us. So the first thing that's done is to trick the body into creating a steady state. The hormonal output is quite variable. It's changing constantly, depending on the day of the year, the hour of the day, whether you have eaten, whether you're nervous, whether you're cold. All of these things affect hormonal output. So how do we create a steady state? Well, what we do at first is start an intravenous drip of a synthetic unit of a hormone called ACTH. And once that has created the steady state, then we bring the patient to a procedure room where there's an X-ray machine attached to a table. The patient will be lying down flat on this surface over a mat. They would be made comfortable, typically with a little bit of sedation. And then we create a sterile field through which to work. Local anesthetic makes the procedure painless. And then we take what we call a catheter, which is just a plastic tube that looks like a long spaghetti that is introduced into the vein that comes from the leg. And from that entry point, we can steer the catheter to the desired locations, which in this case is the adrenal veins. Once we are able to pick off each vein, we carefully draw blood. We give it to the laboratory personnel that are always present at the time of the study to process the material appropriately. And we conclude the procedure. The patient is dismissed. Then we wait for those values to be reported back. Once they come back, a little bit of arithmetic is applied to them to, number one, determine whether the quality of the sample was adequate. And this is actually where, for us, is the nerve-wracking part, where the drum roll is going, because we want to know whether our sampling was of quality that was of sufficient diagnostic value or not. Usually it is, but it's easy to mess up the test. That's why you have to do it very carefully under a well-established protocol. But once we are sure that we have a good quality sample, then we apply a little bit more arithmetic to determine if one, the other, or both glands are responsible. If there's a dominant gland, then we can say, okay, it's right or left. If it's a balanced hormone production, then the endocrinologist will know that it is a case of bilateral hyperproduction or excessive hormone production. The test itself is actually tricky to do, but very safe. It's very rare to have any problems as a result. If something is going to go wrong, it's going to be a poor quality sample, which fortunately happens in a small minority of patients once you've developed an experience and have learned the tricks of the trade. If something goes wrong physically, the most common is going to be a reaction to the contrast dye that's used during the procedure. But even that is not particularly common. If something else might go wrong, it might be some hemorrhage from the vein that we were tickling with the catheter, but that usually has no significant consequence. So we're providing this service to your endocrinologist and the endocrine surgeon so that we can determine a pivotal piece of information that will be used by your other physicians to counsel appropriate therapy.
Yeah, so it's very important that this procedure is done. Again, we only do this procedure if someone is making too much hormone and they have both adrenals have an enlargement in the gland. So it's very important to have this information, to help us decide on the next step. Sometimes if both glands we determine are making hormone, then medical management could definitely be a consideration. In more severe cases where a patient is very symptomatic, then surgery would be necessary. If it's a single gland that is responsible for this hormonal overproduction, whether they only have a single mass or maybe there are masses on both sides, but only we determine one of them is making it, then we really try to encourage surgical intervention, because that's you'll see the most benefit from that and likely cure from that procedure. So just like with the interventional radiologist in performing the adrenal vein sampling, it is also equally important to have an experienced surgeon who does a lot of these procedures, is up to date on various techniques involved, whether it's minimally invasive or requiring open or the approach. And Dr. Ellie is one of our very well experienced surgeons in adrenal surgeries here at Mayo, and I'd like him to help discuss his thought process and procedures a little bit more.
Thank you, Dr. Rao. Yeah, so first, it is an honor for me to be part of this group. As you know, Dr. Paz, Dr. Lego, and yourself mentioned, you know, adrenal glands are not very common, but in our center, we are so used to get these patients because we have a referral center. So for us, as Dr. Paz says, this is kind of a routine. And that's why we developed that expertise that not many places have, because we see patients from all over the country for this regard. So, you know, the good thing about working in a multidisciplinary team is that we can talk to each other and we analyze each patient because each patient is different. So we have the expertise of the radiologist, the expertise of the endocrinologist, and of course, the surgeons. I've been doing adrenal gland for almost 20 years. We were pioneers in developing robotic techniques for this disease. We are cutting edge in that technology. We have the latest surgical robots in the country. And I can say that we can do a very safe operation. Some patients, once we determine a treatment plan, may need some medication beforehand to prepare the patient for surgery. So if the patient needs some medications to regulate the blood pressure or the cortisol, we usually, as a team, we manage that preoperative preparation for the patient. Once the surgery is over, some patients may need to continue with that medication. But as I said before, patients are being evaluated as a group, not only before surgery, during the operation, during the hospital stay, and also after the patients go home. Talking about the operation, we have several techniques ranging from minimal invasive to open. I would say that in our experience, 97, 98% of these procedures are done through tiny incisions, either from the abdomen or from your back. Most of the time, we do 4 tiny incisions that are not bigger than 1 centimeter. And usually those incisions go just below the rib cage on each side, depending on the localization of the gland. The operation usually takes between an hour and 2 hours. And the risk of the operation is minimal. As Dr. Paz says, when you have the expertise of doing these procedures over and over the years, we are very selective and we are very quick in identifying these glands and take them out in a very safe fashion. It's very rare that we have any intraoperative complication like bleeding or conversion to open, which is extremely, extremely rare. Most of the patients will stay in the hospital for about 1 or 2 days, depending on these labs that we do. If there are medications that they need require a more, you know, a scrutiny or a more, you know, we need to do some labs and make sure that the medications are being effective. And usually by day number 1 or day number 2, the patients can be released. The recovery time is about a week to 10 days, and most of the patients can resume normal activities in about a week to 10 days, as I said. The incisions are very easy to take care. Usually we close them with glue so patients can take showers and have a normal diet almost immediately. Usually the postoperative care is combined between the surgeons and the endocrinologists, and we always are in constant communication to make sure that the patient gets the best care that we can provide.
Thank you, Dr. Ellie. Yeah, I mean, it's very important at our institution as well as at other places that we work as a team in this multidisciplinary fashion to help decide what is the best appropriate care for the patient, for you. As I mentioned, you know, some patients due to other medical issues or, you know, if they have both masses, and we don't want to take out both masses because then it subjects the patient lifelong to remain on other medications, then we can treat these conditions medically. And usually myself as an endocrinologist and my colleagues will help facilitate this. And so some of these medications are very well tolerated. So it depends on each patient, and this is where an important discussion is needed with the surgeon to help determine this. So in summary, I mean, I'd really thank you guys for joining us today. You know, this discussion is important. We're constantly talking every day with our radiologists to have, you know, a clear understanding of what this mass may be with Dr. Paz to decide, okay, well, if we have two masses, which one is the culprit, especially if we have too much hormone. And Dr. Ellie, of course, to help surgically manage this to, you know, with optimal outcomes and cure for this condition if needed. But it is very important to note that although these masses are found, the majority of them are benign. They will never do anything to you. It's just a little bump that is present, would never cause any symptoms or abdominal pain. So most of these masses are, you know, are like that. And your endocrinologist or other provider who found this and is working this up can decide the follow-up that's needed. But the other important thing is if you do need any surgery or any procedure, that to make sure that the proceduralist, the interventional radiologist, and the surgeon are very well experienced with these procedures to minimize complication rate and of course to have the most appropriate diagnosis. So with that, I'd like to thank our panel again for helping us out today. And like I said, we work very much as a team at Mayo Clinic, and thank you again, and I hope you gained some knowledge on adrenal masses today. Thank you.
Thank you.